Hey friends, welcome to AOCPMR Podcast. I am Meghan Mardashti, one of the AOCPMR's Multimedia Committee co-chairs and your host for today's episode. For today, we have Dr. Keramati on, who has been on our AOCPMR podcast before, where we hosted them and one of their amazing patients, Mr. Johnson, which I strongly encourage you all to go ahead and take a listen if you haven't. And Dr. Keramati serves as the program director for the Sinai Hospital of Baltimore Physical Medicine and Rehabilitation Residency Program, and she also provides outpatient care to patients with various neurological diagnoses, from stroke to brain injury to multiple sclerosis and spinal cord injury. So, for today's episode, we have something a little bit different than we've done on the podcast before, where we're going to do somewhat of a lecture style, going through different subsections, or if you'd say categories of TBI, with Dr. Keramati, and we will also have some slides, which will be both on the show note or if you're tuning in more virtually, will be shared. So hopefully you enjoy, and yeah, let's dive right in. So how are you doing, Dr. K?
Thank you. Thank you, Megan. Thank you, AOCPMR, for inviting me again to the podcast. I'm excited to be here. So as we were talking, we were trying to brainstorm different ways of tackling TBI. It's such a huge and broad topic. The mantra for TBI is you've seen one patient with TBI, you have seen one patient with TBI. So everyone is coming in with such a unique experience, a unique injury, a unique background of like prior issues that they've had, different psychosocial situations. So that's kind of my little caveat before we get started. We're gonna dive into just a reminder of the definitions of mild, moderate, severe, TBI, how we kind of categorize who ends up being in like what pile in a sense, and then talking about like maybe more, not so much common because everyone's different, but potential like symptoms that we might see for each of those categories, even though these are things that we may see like across the board. So yeah, I figured we'll start with the slides
Awesome. Yeah.
and talk about just the categories to get everyone up to speed on that. So I have on here, this is the DoD definition of mild, moderate, and severe TBI. Different organizations have their own definition. So I'm going to kind of show the slight difference that ACRM, the American College of Rehab Medicine's definition for mild TBI, that is slightly different from this one. And you probably are going to see more of the ACRM definition being used in a lot of like the journals coming out from our major national organizations. So yeah, for the DoD definition, mild is normal structural imaging. So that's that initial head CT that they do. So it should not have any like fractures, not have any like epidural or subdural hematoma, stuff like that. There's 0 to 30 minutes of loss of consciousness, or there's alteration of consciousness up to 24 hours. And what that means is if somebody's kind of like seeming dazed or confused, you might remember like cartoons, you'll see like the little birds like chirping over a person's head. That's kind of like what we're alluding to when we're talking about alteration of consciousness. Post-traumatic amnesia will be, again, anywhere from 0 to 24 hours, and then the Glasgow Coma Scale being 13 to 15. Moderate TBI for the DoD definition is normal or abnormal structural imaging, 30 to 24 hours of loss of consciousness, more than 24 hours of alteration of consciousness, post-traumatic amnesia of 1 day to 1 week, the GCS of 9 to 12, and then for severe, normal or abnormal structural imaging, more than 24 hours of loss of consciousness or alteration of consciousness more than 24 hours, or post-traumatic amnesia more than 7 days, or the Glasgow Coma Scale of 3 to 8. And it might seem kind of weird. Why would there be normal structural imaging for severe? That can happen. We may not really see diffuse axonal injury on head CT at all, and may not really show up so much on MRI either. It can sometimes be alluded to if you're seeing like micropetechiae. So that's like little small vessels like breaking and causing like little areas of bleeding. And it's kind of assumed that there's a lot of diffuse axonal injury, because if it's enough force to cause a little bit of that shearing to the vessels, it's definitely enough force to cause the shearing of the nerves as well. So yeah, that's with the three categories: mild, moderate, severe. I'll have us jump to the next slide that goes into some detail for the ACRM. For this is more so talking about mild TBI, and it goes into a little bit more detail to describe potential the injury itself. So this would still be true for a lot of the other definitions out there. So the head being struck, or the head striking an object, or the head can go through this acceleration deceleration movement. So we kind of think about that a lot for like car accidents, where the head may not hit like the windshield or the bag or anything like that. It might cause the head to come forward and then bounce back with just the acceleration and deceleration of the vehicle. And that can be enough for the squishy brain to hit the really hard skull that it's in, and cause damage. So that's something else that we sometimes need to educate more lay people, that you do not actually need to have hit your head to have sustained a brain injury, but it does need to be a big enough force to cause damage to the brain. And the rest is the same as like the slide we went through previously, but it does not mention anything about structural imaging. So it is possible for using this definition that a person with mild TBI can have some structural imaging findings. And that's just the slight variation for this definition versus the DoD definition.
Got it.
Um,
I actually had a question if
yeah,
I could. So
sure.
with brain injury, this is really interesting. First thing, I think the imaging, because I would personally think with kind of like the shear forces or the axonal damage, it would
Mhm,
potentially present itself as contusions on MRI. So that's really, really interesting, especially with severe brain injury, that
mhm.
you wouldn't have necessarily a lot of, or you could have like
You might
normal
not,
imaging.
yeah.
And another thing is that a lot of times, like at the time of trauma, it's more so CT that's done because MRI takes so much longer. So
Right.
possibly like MRI wouldn't be in that moment, or I guess obtain until much
Mhm,
later. So that's another interesting caveat to keep in mind. But so with these two different definitions of, and like presence of imaging versus not presence of imaging, would you
mhm.
say that then with brain injury or traumatic brain injury, it has to be from a quote unquote traumatic cause, meaning like it has to be this um like traumatic, noxious, I guess it wouldn't be a noxious stimuli, but this traumatic hit to the head for it to be labeled as traumatic brain injury,
It
or
needs to be
Mhm.
a substantial amount of force for it
Mm,
to at least kind of like jostle the brain and the skull.
got
Yeah.
it.
So
Okay.
it wouldn't be like if you were to just like drop a paperclip on your head, like obviously
Right.
the head was hit with some object, but obviously that's not going to be anywhere near enough force to cause like a head injury or the traumatic brain
I
injury.
see. I see. So
Yeah.
something like an anoxic brain injury wouldn't necessarily be labeled as traumatic brain injury.
No, but it is possible to have suffered both. Um,
Mm, that's
so
a good point.
potentially if somebody was in a car accident and they had like other injuries and they had a cardiac arrest,
Mm-hmm.
then the heart stopped. The brain is not getting oxygen because there's no blood pumping up to it. So you could have a scenario where somebody has suffered a traumatic brain injury and an anoxic brain injury. And of course, that is going to be potentially more deficits that the
Right.
person has. We tend to see that those that have suffered an anoxic brain injury have poorer prognosis than those with traumatic. Um,
Got it.
Oh yeah, that's a great question.
Good to know. Thank you. All right. We're gonna try our next slide.
Cool. Yeah, so when we're talking about more of a mild traumatic brain injury, another name for it is concussion. So that's kind of tossed around a lot. And we hear a lot of people use terms like post-concussive syndrome. That really doesn't quite exist as a diagnosis. More accurately would be to say post-concussive symptoms. Because a person may be experiencing a lot of these symptoms after an injury, but it doesn't necessarily, it's not maybe necessarily due to the brain injury itself. Through a trauma, it could be more of like issues with the neck getting tight because they might have a whiplash injury as well. Could be from maybe like bruising along the body, or it could be like the person's in so much pain that they're not able to sleep, and that might cause like cognitive symptoms. So I think that is a bit more accurate thing to say is potentially post-concussive symptoms, is that potentially a person may have had a concussion and now they're having symptoms after this injury, but may not necessarily be just from like the concussion itself. I really like this diagram because it does kind of show the different symptoms that somebody may experience after a mild traumatic brain injury. And I apologize, I'm kind of like using concussion and mild TBI like back and forth. In all intents and purposes, they are synonymous with each other. But yeah, this kind of like really well lays out different symptoms that they can experience from the somatic, where it's kind of like the blurred vision, double vision. They may have vertigo, dizziness. It's really common to have specifically BPPV after these sort of injuries. They can have balance impairment, headaches, light sensitivity, sound sensitivity, tinnitus, nausea, and then more from like the sleep side of things. They can have issues with falling asleep, staying asleep, being really sleepy and sleeping like all the time. So they may sleep like 10, 12 hours at night and then take a lot of naps during the day. And then sometimes that switches to them, they just can't sleep at all and they kind of like are an insomniac. They can have different cognitive symptoms, difficulty focusing, concentrating, difficulty with short-term memory. They may feel like they're in a fog. A lot of times patients will say like, oh, I feel like my head is in like a fishbowl. They just kind of get this like, oh, kind of like foggy sort of sensation. And then emotionally, they may feel anxious or depressed or irritable. And this diagram shows all of these bubbles kind of like overlapping on each other because it can be very complicated and there can be this overlap of the symptoms on each other. And sometimes like one symptom may actually lead to issues with other symptoms. So an example would be that say somebody is having headaches, and you can imagine just remembering when you've had a headache. We've all experienced one in the past, especially with studying for boards and all that sort of stuff. That you can imagine like having that headache, it's harder to maybe read, harder to focus, harder to concentrate. So then that can potentially lead to cognitive symptoms. And then those symptoms that can be kind of distressing for the person. I really need to like be on my toes, be alert, and be there like at work. Now I'm having trouble doing that. So now I'm kind of feeling anxious that I might lose my job. So then that can potentially lead to the emotional symptoms. Then that worrying can lead to sleep issues because now I'm staying up, worrying if I'm going to lose my job. So you can see like we kind of went full circle and just the lack of sleep, then it can cause more headaches. So that's just kind of one example of just picking one of these symptoms and seeing how it may potentially lead to the other bubbles that we have here. And we could do the same thing for pretty much like all of these bubbles. But yeah, that was just kind of an example of it's complicated.
And very
We could move.
multifaceted as well.
Yes,
Mhm.
very much so. And it's really kind of helping the patient with where they're at. And kind of getting a sense of like what is bothering them the most and trying to tackle that first. And kind of creating like your team. So if somebody's having like all of these symptoms here, then we may want to have like um, a medication that's going to maybe help with the headaches, sleep, and emotional symptoms. So it's kind of like cheating, but we're going to talk about it later in the
Yeah.
more of the
Yeah.
sleep
Yeah.
slide.
Yeah.
But amitriptyline or a tricyclic antidepressant is
Mm-hmm.
kind of one you can consider because it's going to hit like as many of these symptoms as possible. And then having like the vestibular therapist on board, they can maybe help with doing the Dix-Hall-Pike and the Epley maneuver for any BPPV, those sort of things. Getting the rehab psychologist or neuropsychologist, whatever psychologist you have at your said facility, getting them on board, potentially having like the speech language pathologist help out with some of the cognitive symptoms, so on and so forth. So it's kind of creating your team to help out this patient.
Mm-hmm.
Yeah. So we'll move on because I wanted to just focus on like one of the symptoms for more of our like not really mild TBI case, but for our mild TBI category
Yeah.
in a sense.
Yeah. Yeah. Yeah.
Um, so we'll focus on headaches. So this is kind of my disclaimer. So we may hear like post-concussive headaches, but that's kind of like what we're mentioning with like post-concussive syndrome. It's not really quite a thing.
Mm-hmm.
Um, it kind of just says that, oh, this person is having headaches after this trauma, but it doesn't really kind of get down to causally what's causing the headaches because it's actually probably less likely that it's coming from the brain injury itself. So I kind of took this from Dr. Zassler's slides. He is absolutely amazing. He wrote the book on brain injury. He gave a lecture at AAP in 2020. So want to credit him for this. But he kind of posed to the audience, which kind of category of brain injury do we see headaches the most? Is it mild, moderate, severe? So we actually see headaches most commonly in mild TBI patients. So that wouldn't really make sense if it was actually from the brain injury itself. If it was from the brain injury, we would assume that, oh, as the severity got worse, we would see more of it. So there's potentially something else going on. It might be other issues like that whiplash I mentioned earlier, contributing to the headaches. Or maybe kind of like stress causing tension headaches, or maybe pre-existing migraines or a new symptom of migraine headaches, so on and so forth. So that's kind of my little caveat.
Mm-hmm.
So we can move on to the next slide. So there's a whole bunch of different subtypes of headaches that we might potentially notice after an injury. So I have them listed here: musculoskeletal, cervicogenic, tension, migraine, medication overuse. So we'll talk a little bit about some of these. Just because you kind of notice an etiology in one of these categories doesn't mean that it's the only etiology for that person's headache. There might be multiple. So kind of keep looking and kind of take those into consideration as well as you're treating the patient. Yeah, so we have musculoskeletal. This ends up being more of like the myofascial pain. So a lot of that tightness in the muscles, trigger points, stuff like that. Things that I think we're pretty good at as a DO with looking at and potentially treating. I don't want to like toot our own horn, but I think our palpatory skills are pretty top notch.
Mm-hmm.
So would encourage everyone to definitely put your hands on your patients, obviously with their comfort level, and
Yeah.
kind of feel around, making sure that they are being fully
Mm-hmm.
assessed, see if there's any areas of tissue texture changes, some of these buzzwords you remember from
Right.
med school, taut tissues. You can definitely kind of feel the knots in the muscles. So yeah, feel around for that, kind of get feedback from your patient, like, oh, is this kind of really bothering you? And when I press here, does it send pain elsewhere? So this can really kind of tell you if some of these trigger points might be, in fact, contributing to the person's symptoms.
Mm-hmm.
Um, this is a wonderful website,
Yeah.
triggerpoints.net. This is kind of a picture from that website. You can really like go to a body area, like say if the person's having pain on the back of the head. So you can kind of click that body area and it'll say, oh, these are the potential muscles that might be sending referred pain to this area. Or you
Mm-hmm.
could do it vice versa, like pick the muscle group and it'll show you where the referred pain is. So this is kind of showing like the upper trap and where the referred pain would be with where the red is being shown in the diagram. So
Mm-hmm.
a great resource to look into and consider. But yeah, the myofascial pain is pretty common. And we can go to the next slide. So different things that we can do for that. Stretching. We can work on stretching the areas that are tight, strengthening the other opposing muscles to kind of support that body area, referring them for physical therapy. Our physical therapists can do myofascial release, so we can do it as well, time permitting. They can also do dry needling, spray, stretch, different types of massage techniques, using TENS units. This is called instrumental assisted soft tissue mobilization. That's kind of this metal piece that's being shown in the diagram here, and they will kind of push that along the course of the muscle. Uncomfortable, but it works. So it's another technique that they can try. Of course, we can do OMT for this and kind of whatever technique you're comfortable with and the patient will be comfortable with. Potentially you might want to do some of the more gentler techniques if it's pretty soon after the injury, and then potentially trying things that are a little bit maybe more vigorous as your comfort or the patient's comfort.
Mm-hmm.
Different anti-inflammatories that we can do to help reduce some of the inflammation in the muscle. Different muscle relaxants. My go-to is tizanidine, but really could do whatever you're comfortable with and the patient's comfortable with. A lot of times it ends up being like a dialogue with the patient that kind of going through different treatment options, and we're kind of deciding together what we want to do for that particular person. Tricyclic antidepressants or SNRIs, they're also good as another medication to consider for our patients, and then also trigger point injections. And we can go to the next bit. Another thing to consider, and I'm a little bit guilty, I do need to check this a bit more frequently for my patients. It is possible to have more of a myofascial issue to the TMJ. So sometimes with the whiplash and the kind of acceleration deceleration force with car accidents can cause the jaw to come down or get stretched, or cause aggravation to our jaw muscles. So that can end up causing issues there, and we can look at doing I don't know if I have it on the other side, but you could do like physical therapy. There's some physical therapists that are trained specifically to do TMJ therapy. Some of them have been trained to do some of those intraoral techniques. I'm sure you guys remember some of those in
Yeah.
school. I remember that being a kind of awkward
Yep.
class. Uh, but yeah, of course, you would want it gloved and have the person's consent, but potentially going in with a finger and pressing on those pterygoids, see if we can get them to loosen up. So that's an option. There's also different injection options.
Mm-hmm.
Those aren't really anything that I'm personally comfortable with, but certainly other physiatrists are and can be considered for our patients. Usually we have them start with more like conservative measures, maybe doing the therapy doing more like softer foods because that's going to be less aggravating for their jaw muscles. And then slowly increasing to more harder or more difficult to chew foods as they feel better.
Got
We can go to the next slide.
it.
Okay, yeah, I did have some of the stuff on here. I totally forgot. So yeah, what I already said. Bite blocks are another option. I mean, mostly with those is to make sure that the patient doesn't like crack their own teeth.
Oh.
That could be like another option too for
Hmm.
TMJ. All right, we'll move on to the next one. So cervicogenic headaches. This is more so from potentially the trigeminal nerve or some of the cervical peripheral nerves like C1 through 3, or it could be from the occipital nerves. So any of these pain areas can send nerve signals to the trigeminal cervical complex that's kind of in our brainstem and upper part of the cervical spine. So all of these nerves end up kind of converging to this area and then can modulate and send signals back and forth. So it ends up kind of getting confusing which area is the true pain generator. But all of those areas kind of get lumped into more of that cervicogenic headaches. So the pattern ends up being kind of more back of the head and radiating to the front, the forehead area. And it could be unilateral, it could be bilateral. They may have some like blurred vision or other visual symptoms with it, can have some of the dizziness. And really like treatment is kind of trying to tackle which nerve or which of those areas actually might be triggering or causing that irritation and sending the signals to the other parts of the trigeminal cervical complex. So occipital nerve blocks are pretty common for us to try. I might just start off with more conservative of like non-steroid anti-inflammatories or maybe like a medrol dose pack, so about just bringing down the inflammation to the nerves overall. Then maybe considering the nerve blocks. And then that doesn't work out, I would refer to one of my interventional colleagues to maybe consider a facet joint or medial branch blocks.
Mhm.
And we'll kind of go to the next slide that kind of shows a little bit more graphically what I'm talking about with that trigeminal cervical complex, with all of these nerves kind of from the trigeminal nerve, from C1 through 3, and the occipital nerve kind of all converging to that area. And the signals just kind of keep going back and forth. So kind of hard to say where it's all coming from, but that will be the typical pattern that you might see. And we'll kind of hold it there for talking about more of the mild brain injury and kind of headaches.
Mhm.
Um, and yeah, I guess we'll maybe step into, I guess,
Oh,
moderate
okay.
TBI. We don't really have like a segue per se.
Sure.
Oh,
I think a couple of notes on the mild
yeah.
TBI, which I found really, really interesting. The first thing is I love how with all the different modalities, you always mention whatever the patient is comfortable with or have a
Mhm.
preference, and more so that it's a dialogue between you and the patient. So that's
Definitely.
definitely always a great, great reminder for all the aspiring physiatrists out there that no matter what, our patients' priorities and goals will be part of the conversation, which is really great. And I think the complexity of because we think just headaches, right? And I can definitely
Mhm.
see where someone present both with myofascial and cervicogenic, because even
Mhm.
prior to an injury, we, you know, average Americans, we live pretty sedentary lives. And we're, if we think about the upper cross syndrome with super facilitated traps and our traps are more so weakened and kind of stretched with like not the best posture, and then you add a whiplash injury to it, it
Mhm.
could be pretty complicated with you could have some myofascial and cervicogenic um, So definitely trusting our palpatory skills, but also I can definitely see where we try, first line, maybe some OMT, some PT, and it not responding, where we would then have to
Mhm.
go to possibly like the trigeminal nerve block, where it is a bit more invasive.
Mhm.
So,
Yeah, and we didn't really get to some of the other one, like the tension headaches, which just is more
mhm,
like the band around the head, that ends up being more like potentially from stress or poor sleep,
mhm,
dehydration, nutrition, maybe like a drop in like glucose.
right.
Um, with the medication overuse headaches, where like you see a patient and they've just been using Tylenol like on repeat, like every 4 to 6 hours. And they just kind of have this rebound, like, okay, the Tylenol helps for like a couple hours, and then once it wears off, they have like a raging headache. So that's kind of like what medication overuse headaches are like. It's just from all of these like short acting.
Right.
And just like migraines, where they may or may not have an aura.
Hmm.
So they could have like a combination of all these or all of them. So it ends up being like really complicated. But yeah, definitely like talking to the patient. You guys, you are a treatment team with your patient. If you're not able to um, have that dialogue with the patient, they may not be so fond of what you're recommending. They may not
Hmm.
really follow through. And we want them to be as successful as possible in their treatment.
Right. Absolutely. Um, Now, moving on to moderate TBI, where you mentioned how imaging here could either have normal or abnormal presentation depending on
Mhm.
what school of thought you go through. What would you say is, I guess, the biggest presenting symptoms? I guess as I'm asking that, I definitely can, think of all the criteria you listed with like different loss of consciousness, different
Mhm.
GSW phases. But I guess as a patient sitting in front of you in
Mhm.
an outpatient setting, what do you note to be the biggest telltale sign of moderate TBI versus, let's say, like concussion or mild TBI?
Mhm. Really, honestly, there isn't one. Yeah. Oh, we only know because of the records kind of point to one
Mm,
category or the other.
right.
But yeah, it's kind of the same motto of like you've seen one TBI patient, you've seen one TBI patient. Um, Maybe they might have a little bit more of the common symptoms, but not necessarily. Um, yeah, they're all kind of coming in with their unique set of circumstances, unique symptoms. So it's not really any defined one thing or another that we see for like moderate that we may not really see so much for mild.
Hmm.
Um, the symptom that I kind of picked for us to talk for this patient population was more sleep. So we can
Hmm.
talk a little about just different things that we can do for patients that might have difficulty with like sleep initiation or sleep maintenance. Because just helping them improve their sleep can be a great um, part of their recovery. And we definitely need sleep for our brain to help lay down new memory. We need to go into REM sleep. That's kind of how we do
Hmm.
it. It's going to be really important for their recovery. So yeah, so maybe we can
Right.
delve into a
Yeah.
couple of those slides.
Yes, absolutely.
So yeah, with sleep disturbance, and I really ask patients to get into a little bit more details with me about this. Is it difficulty falling asleep? If so, how long is it taking for them to fall asleep from like when they get into bed to eventually when they fall asleep? Is it more of a sleep maintenance, which means that they're potentially waking up repeatedly in the middle of the night? And why do they think they might be repeatedly waking up? It could be like they're having a lot of pain, so maybe the pain might be waking them up. A lot of times I hear from patients that they're worrying and they notice their mind is racing, and that's kind of keeping them up. Some people might be getting up because they need to go pee and they just need to use the bathroom. And maybe they're able to come back and fall asleep, or sometimes they're not able to fall asleep. So, those are some details that we want to get from patients. Also, if they're taking any naps during the day, So that might be really throwing off the sleep-wake cycle. If they're sleeping like 4 hours during the daytime, they may have a harder time falling asleep or even staying asleep at night because they just slept so much during the day. So then we have to work with trying to reduce those naps and extend the time that they're sleeping in the evening. So these are some of the things we can consider for patients with a sleep disturbance. Sleep hygiene, which I have discussed a little bit more in the next slide. We can have our psychology colleagues to help us out with the patient with doing cognitive behavioral therapy for insomnia. It's kind of a regimented type of behavioral therapy. I don't exactly know what it is, but I think they will try to get them to consolidate their sleep at night as best as possible. So having their sleep window to be like more like 5 hours and then slowly extending that out. So it is a kind of a challenging treatment regimen, but it is actually the gold standard for insomnia. There is no other treatment method that is more successful than cognitive behavioral therapy for insomnia. But again, the patient has to buy into it because if they don't, then obviously, regardless of what you do, it's not going to be very successful. We have a whole bunch of different medications to consider. I've listed a couple of them here. Melatonin is really great, especially for somebody that's a little bit hesitant about taking any medications at all. We do notice for brain injuries, sometimes there's a depletion of natural melatonin in the brain. So this could just be a nice way to help supplement that. It is used more so for sleep initiation. So it's more so for that patient that's having difficulty falling asleep. I've noticed for a lot of patients, they say after taking melatonin, they end up waking up about like 3-4 hours later. So it's not so great for that sleep maintenance, much better for the sleep initiation. Trazodone, on the other hand, Remeron being another one, is a bit better for that sleep maintenance, so helping the patient stay asleep a bit longer. So both of those are considered SSRIs. It is possible if you want to do a combination that you have them do melatonin and trazodone, but again, it's kind of meeting the patient where they're at. Amitriptyline is a pretty good one to consider because it can hit a lot of the symptoms the patient might be experiencing. It is sedating, so it can be good for sleep. It is a tricyclic antidepressant, so it can help with mood. And it is used for pain. So it may help with person's maybe myofascial pain or a headache. So it's kind of a nice one that hits as many symptoms as possible. And anytime I'm kind of thinking about what sort of medication regimen I want to try for a patient, I want to see if there is that one or maybe two medications that will hit as many symptoms as possible. So I do want to reduce any kind of polypharmacy. A little bit of a caution for amitriptyline itself. Of all the tricyclic antidepressants, it has more of the anticholinergic side effects than any of the other ones. So anticholinergics, not so great with cognition. So this would be more so a consideration for our younger patients. If they're 60, 65 or older, or having a lot of cognitive deficits, we may want to pick something else. Okay, yeah, we can go into the next slide. Thanks. All right, so this is talking about sleep hygiene. There's different tips that we can give patients. Tips during the day, tips during the night. Biggest thing that you'll hear about sleep hygiene is that they need to only reserve the bed for sleep and sex only. It's kind of like the mainstay of sleep hygiene. Different things they can consider during the daytime is picking the same time that they're waking up every day. This even like considers the weekends, which is really hard for patients. They always want to sleep in. But as best as they can to stick with a consistent wake up time and a consistent bedtime. That routine is really great. Avoid oversleeping. So that will be more like 9 hours or more. Sometimes oversleeping can cause somebody to feel more groggy. So that's encouraged to reduce that. Sunlight, blue light can promote wakefulness. I think there's some alarm clocks that are starting to use this now, where you set the time and then it will maybe give some gentle sounds, but it will slowly bring up a slightly brighter and brighter light. And that's kind of giving more of the blue light to help simulate sunlight. So that could be a great way of feeling a little bit more wakeful when they wake up. This is always a hard one. The caffeine. Trying to avoid more than 1 cup of caffeine. Um, it ends up being a little bit of battle for some patients. I had this one patient that I was like, oh, how much like coffee do you drink? And he was like, oh, like 3. And I was like, oh, 3 cups? No, 3 pots. Three
Oh my
pots of
goodness.
coffee. Yeah, he'll just
Wow.
drink that throughout the whole day. So yeah, no wonder he was having some sleep issues, some anxiety. Yeah, so had him slowly wean down. We have somebody that's on like such high doses of caffeine. We want them to wean down and not just stop cold turkey, because then they might just get like caffeine withdrawal, like headaches.
Mm-hmm.
But yeah, that was more on the extreme side. But yeah, we want to have them just kind of stick with 1 cup of coffee. And I usually tell them to do it like before noon if they can. I mean, that will kind of depend on the person's schedule, but yeah. So it's
Mm-hmm.
not going to be like too late in the day either. Exercise could be really good, kind of wears us out, makes us feel good, can be a great way to sleep a little bit more soundly. And then avoiding the naps, kind of keeping them pretty short. So we want to have it more as like a cat nap, and to have it like earlier in the day too. So we usually say like 3 p.m. or earlier, to take those naps if they really, really feel like they need to take the nap. And then
Mm-hmm.
evening time, something that they can do, again, consistent bedtime, maybe like a bedtime, like relaxation routine, just to wind down. Um, could be listening to relaxing music, having some like chamomile tea, smelling some lavender, whatever it is that, floats their boat.
Mm-hmm.
Um, and trying to avoid like sleep anxiety is kind of how they describe it. So it has this example of, even if I cannot sleep tonight, I will survive tomorrow. Some people will kind of get into that cycle of like, oh, they keep looking at the clock. It's like, oh no, I'm only gonna have like 4 hours of sleep. I'm not gonna make it. Like, and then you just keep worrying, and then that just kind of ends up being a vicious cycle of not being able to fall asleep, having less sleep, and then feeling anxious about it. But that could be a little mantra that like, okay, tonight I didn't really get that great of a sleep. That's fine. I'll still be fine tomorrow. We'll get through the day. It'll be okay.
Mm-hmm.
Um, and turning around the alarm clock. Yeah, same sort of concept. Stop looking at the clock. And I think the alarm clock can have a bit of a glow to it. So I think keeping the room as dark as possible is also good. Light snack before bed, that can help. Some people, I know I kind of need to do that. I need to feel like a little bit full before I can like fall asleep, or else I'll wake up in the middle of the night and just want to go grab a snack. So, just like a light snack can be helpful. Definitely avoiding alcohol. It's a struggle for some of our older patients that have maybe been prescribed benzos to help with sleep and have been on it for decades. Um, if they are able to slightly at least wean down a little bit, that will be
Mm-hmm.
better.
Mm-hmm.
But any of these benzos, alcohol, they can suppress REM sleep, and it's really not the best. So trying to avoid that as best as
Mm-hmm.
possible. And
Especially with a brain injury as well.
yeah, exactly. Yeah, for sure. They shouldn't be drinking it anyways after a brain injury.
Mm-hmm.
Yeah, so next slide, I have just different things that we can have the patients consider trying. Even things that we can consider trying ourselves if we're having difficulty sleeping. Um, Supportive bedding, like, or just finding that pillow that like really feels good, or that mattress topper that's supporting you, Weighted blankets, I've heard different things from different patients. Some people feel like it's great, like they feel nice and cocooned, and they really love it. It helps them sleep right away. And then other patients, I feel like it's just way too hot, and they just can't like stand it. I've had one patient that had the weighted blanket and felt like it was putting too much pressure on her back, and it actually was causing some back pain. So, kind of stayed away from that for her. So again, it's kind of like a lot of trial and error, seeing what works for them. Room temperature, cooler room can help promote better sleep. Um, so that could be something for the patient to try. Summertime can be really difficult with that since, well, I'm here in Maryland and yeah, the heat and humidity can be a lot. I'll tell patients to try like fans, see if that helps, because that gets to maybe cooling the temperature of the room, but maybe even providing some like white noise as well. Lighting, this is kind of like the opposite of using the blue light to keep you awake. We want to turn that off and maybe use like more of an amber lighting, or preferably to like not have screens or devices in our faces, since the that lighting can tell our brain that it's daylight and we should be awake. So having the room as dark as possible. And yeah, different sounds, the white noise, it's kind of like a noise machine we have in the diagram there. You can try different earplugs. Um, Binaural beats is kind of a, again, like a relaxing-ish sound. Um, ASMR, I think, is a little weird, but some people like it.
I'm just laughing. I'm laughing because yeah, I personally use multiple of these modalities for
Yeah.
sleep. Where I actually binaural beats, I've heard it's really good for concentration and like
Oh, okay.
initiation of, yeah, I'm somewhat of a, I know Andrew Huberman now has more like a controversial following, but I feel like his from his science angle, that's been
Mm.
something that he has studied and it's shown, especially for initiation of bouts of focus, binaural
Oh,
beats
cool.
allow you to focus, especially if you tend to have like some neurocognitive distinctness like ADHD.
Mm.
It can be pretty helpful. But I personally use like the eye mask, the white
Mhm.
noise. I light up the candle. I
Nice. Yeah, get
lower
the
my. I'm
aroma.
like, yeah, this is like pretty. I'm like, okay, this is great. I'm like using a couple of these, so trying
Right.
to work on my sleep hygiene personally.
For sure. Yeah, yeah. And my combo is more the room temperature, eat a little snack before going to bed, the white noise.
hmm
Yeah, those are my like go-to. Yeah, and everyone's gonna have their different combination. That's really interesting about the binaural beats. I didn't know about that. Is there a specific frequency as far as you know? Like, because it's kind of like the
Yes.
two different tones,
Yeah, yeah,
that ends
yeah.
up kind of like somewhat canceling it out and kind of causing this
Yeah,
like
I'm trying to think
wave-like
if
sound.
yeah, it was either between 70 or 40 hertz.
Mm.
Oh, it was 40 hertz. Yes.
Oh, cool. Did he
Yeah,
notice if there was other sound or other frequencies that were better for other
that is a
instances?
great question. I just
Maybe
remember like
something
my
to
biggest
research.
takeaway. Yeah, yeah, no, for sure. And it's because also there's different ones where like it's binaural beats layered with other sounds, but this is for more so 40 hertz pure
Mm,
binaural beats. Um, that is like good for focus. So,
cool.
yeah.
Yeah. So I think
Um,
that's it for our slides.
all right.
I think our last bit, I guess we could just like on
Mhm.
share. Um,
Oh, this was amazing. Um, I also I think the first question I asked about the
mhm,
presentation of a moderate versus mild TBI, because I think once you haven't had the exposure at the stage that a lot of the listeners, including myself, are, it's
mhm,
it's easy to see if someone is at inpatient rehab with more so visual disability that you can see, okay, they have aphasia,
mhm,
they have ataxia, or you have had access to their records. But then I think the other layer is like if I were to see someone in an outpatient setting, would I be able to tell? And that's
Right.
really fascinating, genuinely not that you could have someone, which, for instance, Mr. Johnson, who came
Yes.
on the podcast, I'm not sure if for him his level would, or it would be severe versus moderate, but
Yeah. I think he was kind of mentioning like he was more or less in a coma. He meets the definition of a severe traumatic brain injury. So
right.
that's what he suffered. And as or hopefully you will see if you haven't checked
Yeah.
out that podcast already. If you haven't, again, we recommend that you do, but he is
Hmm.
doing absolutely amazing.
Right.
He has recovered quite significantly that,
Hmm.
he would be doing better now than potentially a lot of patients with mild and moderate traumatic brain injury.
Exactly.
Um,
Exactly. And that's the beauty. And like you said, you've seen one brain injury patient, you've seen that one brain injury
mhm,
patient. So it's always really, yeah, it's important to keep that in mind, which adds another layer of complexity, but also how unique brain injury can be. And I think talking about sleep, especially in the realm of moderate TBI, especially that, like you've mentioned, sleep is such an important factor for a recovering brain, like let alone I think as a someone without a disability, sleep is really important because that's
mhm,
when, especially if you're growing, your growth hormone levels are rising, your memories, your working memory is solidifying. So it's just
right.
beside how important that is in someone without a brain injury, then add the other layer to it, it becomes also a
Definitely.
lot more important. And these were really tangible, accessible tools that we all can advocate and educate our patients on.
Mhm,
Um, and that's what I really, really appreciated about it. It's like, yes, these can look very simple, but if we're able to share that with our patients and
mhm.
able to help with their sleep quality, that will then positively influence the recovery journey.
Definitely. Yeah. Yeah. Well said.
Awesome. Awesome, awesome. Um, and now I guess we can move on to severe
Yeah,
TBI.
sir. Yeah. For whatever it's worth. And again, you can potentially have the same symptoms as we mentioned in those bubbles when we talked about mild brain injury. They may potentially have more of the kind of symptoms, potentially less of the headaches because we actually see a lot less of that in more moderate and severe brain injury than in the mild. But more so to kind of talk about that these patients may present in so many different ways that, like our patient, Mr. Johnson, doing really great, more so had some weakness and the aphasia primarily that he was dealing with. And then I have other patients more on the more extreme end of the spectrum that are maybe completely aphasic, maybe saying one word or nodding, um, needing to have really total care. They're dependent with mobility, so they're needing to be pushed in a tilt and space manual wheelchair. They need to have total care and are dependent for all ADLs, may or may not have a peg tube for feeding. So you can see that the care that this person needs and the resources that they'll need is very, very different than somebody like Mr. Johnson.
Mhm.
So that can be very, very challenging, especially on the family. So that's kind of more to talk to the audience that this does need to include family into the conversation. It's not just talking to just the patient itself. A lot of times we're needing to include family members, friends, whoever is part of that person's community to help them out. And unfortunately, there's some people out there that don't have a big community, which can be extremely challenging. And then unfortunately, we're potentially looking at like nursing home placement.
Mhm.
But hopefully, if there is a person that has some family support, then we want to see what we can do to support them as best as possible. Um, different states will have different resources. Their insurance might have different resources they might be able to tap into, their own resources. It depends on kind of like the means of the family. So if they're able to hire an aide, that could be really helpful. Um, some states will have ability through insurance to cover maybe a couple of hours with an aide. Um, a lot of the states might have a waiver program, so a program where the family can apply and see if they're able to have an aid for a more longer duration.
Mm-hmm. Mm-hmm.
So that's an option. One of my patients that has a pretty severe brain injury that kind of meets the description I mentioned earlier. His case was interesting because he had an accident in a casino. So he fell from a very high distance, suffered a very traumatic brain injury. He was categorized as severe, and they actually had a settlement with the casino, so they have a medical set aside. So there are some people that it may have been in such a scenario, or it could have been a workers' comp injury or maybe a car accident. And if there was a potential settlement with that case, they may have some money set aside. So their family is using that set aside to hire an aide and a nurse to help the patient out. So, which is really great because he's able to actually stay home and get the care instead of being at a nursing home.
Mm-hmm.
So yeah, there's kind of like different scenarios there. Sometimes the family's kind of like taking everything on. They may have like different shifts. Some states are able to have family get paid to be like caregivers.
Wow.
I guess it depends. Like for Maryland, if it's the person's like parent, they don't really count that as like a caregiver. It's really stupid. I don't like it. They're like, oh, it's a responsibility. It's like, no, no. They really
Yeah.
should get compensated for that work. So I think that's really crummy, but different states might have maybe different definitions of or different leeway of who may be able to get compensated as a caregiver for the patient.
Mm-hmm.
So that's a possibility. Um, Talking to our social work friends, they may know of other resources. It's possible to arrange for caregiver reprieve or
Mm-hmm.
or support where like the patient goes to a facility just for a short period of time, maybe for like a couple weeks, just to give the caregiver a break so that they can actually recharge and then be available for the patient. So that's when I call on my social work colleagues like, hey, can you give them this family some resources, what they could do to give them a little bit of a break. Um, our social workers may also have like additional resources that I may not be familiar with that they might be able to tap into maybe to help with like equipment or like maybe other organizations that might help with like covering an aid or something like that.
Mm-hmm.
Um, our psychologists are able to do caregiver support for family. Sorry, give psychological support to caregivers. So as long
Mm-hmm.
as um, they're our patient, then that caregiver for that patient can receive those services. So I think
Mm-hmm.
that's kind of really important. So
Absolutely.
yeah.
Yeah. I I think that's very important to be discussed with patients who've had a severe TBI because a lot of times um, they could have we've seen the beautiful example of Mr. Johnson, but then there will be those cases where patients will be dependent for all activities of daily living on patient or on their family, on their support system, and caregiver burden is absolutely something that as future physiatrists, we need to be
Mhm.
mindful of, um, because it takes a lot of time and energy from those who are providing that care. And I honestly don't think outside of physiatry there's a field that it's so attended to, but
Hmm.
also very importantly discussed on, like part of the discharge planning, part of
Hmm.
who is going to support this patient, and having those conversation with the family members, with the friends
Hmm.
becomes very, very important for the success of our patient, but also I'm pretty certain that will hopefully prevent future admissions because, like, let's say, I know we're in the setting of brain injury, but like let's say in the
Hmm.
setting of us, actually even in the setting of a brain injury, if we have like the autonomic dysreflexia, right, if the bladder
Hmm.
care isn't appropriately attended to, that could then I'm sorry, I said autonomic dysreflexia. I meant to
Oh,
say
spinal cord, yeah. You might-
neurosport.
okay.
I meant to say
Bladder issues are
neurostorming.
there for brain
Yeah,
injury
sorry,
patients too.
my
Yeah, for
brain.
sure.
Yeah, I
Yeah.
meant to say that's the paroxysmal hyperactivity, PSH, paroxysmal sympathetic hyperactivity or neurostorming. Like someone
Mhm.
can go into neurostorming, and I know like depending on if it's like closer to the injury versus farther, but I'm thinking like if bladder isn't well attended to, that could
Mhm.
serve as a noxious stimuli, could be a possible hospital admission. Versus if
Right.
the caregiver is appropriately educated, and to the best of the team's ability, I guess those area of, do you need more support? Do you need more, yeah, more support? Then hopefully we can prevent our patient's future readmission to the hospital. So that was kind of like more of a hypothetical scenario I've thought of, but
Yeah,
I'm
for
sure
sure.
if
Yeah, just preventing all those secondary issues. Yeah,
hmm
um with the neurogenic bladder, bowel, skin issues, if they're not being
yeah.
able to turn them properly.
hmm
Yeah, those are all these kind of preventative things that we want to educate the family about and have them follow through on. Yeah, again, like you mentioned, to prevent um another hospitalization, or God forbid they have like an infection or
hmm
sepsis, or
hmm
have horrible wounds and osteomyelitis. Like, we
right,
definitely want to prevent those.
right, absolutely.
Or on the
And
spasticity
using
side, getting contracted, and yeah,
right,
all
right,
that
right.
stuff that kind of happens with that. Yeah, it's a lot
Absolutely.
of care. It's more than a full-time job to help care for some of these patients. And it sometimes ends up being a lot on family. Um,
hmm
so kind of supporting them as best as we can
For sure.
in the unfortunate constraints that we have in our healthcare system.
Right.
It's kind of
Yeah,
the
I
truth of
think
the matter, unfortunately.
for
Yeah,
sure. Utilizing our amazing social worker, case manager, and I
for
think
sure.
even being familiar with the extra resources that might be in our communities, depending on the
Hmm.
state. I've
Definitely.
definitely seen where more independent organizations have started scholarships or funding for families and patients.
Hmm.
So it can be, wearing different hats, but I think that's the beauty of physiatry, where we can be more than just a traditional, picture physician, and be
Hmm.
that genuine support for our patients and families. And I think this was an amazing talk on painting a very multifaceted picture of brain injury. Because I think, especially for our listeners who might be in first, second year of medical school, or even third, and haven't had exposure to brain injury, it's very
Hmm.
easy to hear. And I know, at least for me, the first thing that would come to mind would be pretty much the severe brain injury image, and just would be like, okay, so can this patient genuinely do? But I
Hmm.
think after this, just understanding how it's a lot more than just a patient, it's definitely the family, but also we have so many tools, and brain injury can look very, very different. Um, and obviously, at all times, you want to be able to prioritize the patient and have a very patient-centric care, and while maintaining patient autonomy, even in severe brain injury, when
Hmm.
patients might not be able to communicate, but reminding families of, what do you think your loved one would want in this situation?
Definitely. Yeah. And still address the patient.
Right.
They may not be able to communicate, but they may still have some ability to hear and understand.
Yeah.
So definitely kind of addressing them, acknowledging them and saying hi to them.
Of
That could be a
course.
great way to assess, like how they're doing as well.
Hmm.
Um, yeah, and then getting updates from family as well.
Absolutely.
Sure.
Awesome. Well, was there anything else that you'd like to add as we are going to close
Oh,
today's episode, Dr. Kiramati?
um, I mean, I guess we could go on for hours and hours on this topic because TBI is just so vast. But again,
Hmm.
just coming back to the you see one TBI patient, you see one TBI patient. And I think you already summarized it very well that we want to make sure that the patients are our focus, having them be kind of like driving their treatment course. We want to be their partners in their recovery. And then especially also including the family and other support group um, is part of
Amen.
their recovery too. Yeah. So,
Amen. I love it. That is definitely one of the golden nuggets that I will carry with me for the rest of my career.
yeah.
As you've seen one TBI patient, you've seen only that
Yes.
one patient. That's
Yeah.
very, very important. Well, thank you so much to
Oh, my
everyone for,
pleasure. Thank you for
yes.
inviting me again. Yeah.
Yes. And to our wonderful listeners for listening to this episode. I hope you found it just as helpful as I did and learned a lot about brain injury. If you guys have a few seconds, it would be amazing if you could leave us a review on our Spotify or Apple Podcast page and let us know what you'd like to learn more about in the future. Until next time, and thank you so much, Dr. K, for being here with us.
Thank you.